Oh,
So
it's
I
been a
guess
rough
can you
day.
show me how I can mute Jacqueline? Like, where's the button for that?
I'll just go ahead.
Did,
I'll mute
did
myself.
did you just put your jacket on?
I sure did. I never leave home
Amazing.
without it.
Amazing. Well, we're starting to get we're a good number of participants on now. So, um, Jacqueline, do you have access to the chat thread?
Wee wee.
Okay, perfect. So maybe we'll get both David and Melanie to unmute, and we'll just do some introductions and get this started. So, Melanie, can you hear me?
Yes. Yes,
And
I can.
David,
Yep,
awesome. And David,
I do.
perfect. So, thanks everybody for tuning in. This is our first kick at the can at webinar version rather than a simple Zoom. So, what you'll see in
Wow.
front of what
You just froze.
did I freeze?
Webinar, like cut
Can
out.
you hear me now?
Yeah.
Okay, so our first kick at the can at webinar version. So, what you'll see in front of you is the panelists, but not all the participants. We are recording, so if we want to use this later for educational purposes, we can. And I guess without further ado, let's do some quick intros, and so that way people know each other. So, Melanie,
Hi.
who are you? What do you do?
It's a loaded question. I'm a first-year family resident at the Moncton site with Dalhousie.
Okay, and you're doing your emerge rotation now, eh?
Yes, I am. Yeah.
Awesome. David, you're on your way out, eh?
Yeah, just finishing up second year and also doing a emerge rotation, emerge elective actually.
Awesome. Thanks for agreeing to do this. We'll get into the rules soon so you guys don't hurt each other. And I mean, so I think there are names on here that I don't recognize because we have some students from Mun and Dal zooming in from around the Maritime. So my name's Angus. I'm an emerge doc in Moncton and currently the med ed coordinator there. Jack, who are you?
I don't know half the time. My name's Jacqueline. I'm an emerge nurse in Moncton as well. I also help participate in the simulations with the Dalhousie site here with the med students and the residents. And yeah.
Sweet. And last but not least, I feel like this man needs no introduction, but I'm going to let him introduce himself. Alan, how are you, my friend?
Now that I'm graced in your presence, Angus, I'm fantastic. Thank you. Name's Alan. I'm a nurse out here in Vancouver. So first and foremost, thank you very much for accommodating or staying on the Zoom chat so late. It's only 4:30 out here. I know it's 8:30 in Atlanta, Canada. I primarily work in the emergency department and ICU at Vancouver General Hospital, which is the provincial referral center. So stoked to be on here. In fact, just used the device that we're going to be talking about today this afternoon. I just used it this afternoon.
And that's why you're here, my friend. I'm so excited. And you're what do you tote yourself as, a co-bro on Recess Tonight?
Yeah, co-bro, co-dipshit, however you want to describe myself and Rob. We're a couple of foamite fiends. We are vociferous supporters of it. You can find us at Recess Tonight. We do a bunch of foamy stuff, and I hope someone reads it.
Oh yeah, I mean
no one reads it, Alan.
We've been lucky enough to do some work together, so it's been a lot of fun. So we titled this talk "People versus Pistons." So being very looking at a mechanical versus manual CPR approach for cardiac arrest patients.
Prior to Angus, you should mention
yes.
about the questions in the question box, whatever.
Thanks, Jack.
Sorry.
Thanks, Jack.
Yeah.
So if anybody watching has questions, please just put it up in the chat thread, or you can do the Q&A, but the chat is just fine as well. But completely up to you, and we'll try and get to as many questions as we can. And I think Jack's going to monitor the chat stream for us. Is that right?
Yep.
Awesome. So we flipped a coin earlier, and here's how this is going to go. So Melanie is going to provide us with a great argument as to why mechanical CPR devices should be used. And then David's going to have an opportunity after that to talk about why they might not be so useful. And then, of course, we're going to allow time for rebuttal between the two of you. Now, there'll be funny business, but no funny business. So there'll be no ad hominem attacks. So please don't attack the person, attack the argument if you want to. But we're going to keep it kosher every way else.
Okay, he's gone wonky again.
Yeah.
Am I wonky again?
Yeah, you eloquently demonstrated how sometimes technology can kind of crap the bed and not work as well as we like. But I'm actually arguing against, and David is arguing for.
That's right. You got it. David's
I see a lot
against.
of relief on David's face right there.
And so the reason we're doing it is at a local level, we're about to see potential use of a Lucas device. So we thought it would be wise to educate our department and anyone else who wanted to attend for that matter. So how about David? Let's hear your pro or for argument for mechanical CPR.
Sure. So what I start off by talking about is what makes up good CPR. And from ACLS, we know that for out-of-hospital arrests, there's a chain of survival, and there's a few elements to that. First, recognizing that there's been a cardiac arrest, but the two other cornerstones to it are early defibrillation and also early high CPR. Unfortunately, cardiac arrest has a poor prognosis for many patients. Only 10 to 25% will initially recover, and then even fewer will be discharged from hospital or have a good neurological outcome. And to optimize whatever outcome patients have, some recommendations for CPR are achieving a rate of 100 to 120 compressions a minute, and having a compression depth of about 5 to 6 centimeters. But this is really hard work. It's extremely fatiguing on whoever's doing the compressions. Not only that, but the compressions, they're supposed to simulate cardiac contractions and eject a blood volume from the left ventricle. But the best we can really hope for from external compressions is only about 25 to 30% of blood, a normal blood volume being ejected from the heart. So if someone is doing external compressions, they may be able to maintain a pretty good rate and depth for the first minute with about 90% target of the appropriate rate and depth. But that quickly drops off over the next minute to 5 minutes to 67%, 30%, and as low as 18%. And that's from operator fatigue, the compressor not recognizing that the quality of the compressions is deteriorating. So in this case, we have to ask ourselves, is there, if humans can't do it perfectly all the time, why not get a machine to do it that can be adjusted to go at the appropriate rate, appropriate depth, and the appropriate location to optimize the outcome for these patients as much as possible? There's two main types of devices on the market. There's one example is the Zoll AutoPulse, which is a compression band type device, which wraps around the circumference of the chest and circumferentially compresses the chest wall to do the compressions. And then the other type of device is kind of like a piston type device that is called the Lucas, and it applies compressions through a piston over the sternum. And although the two devices haven't been compared head to head, and it's hard to know which one may be superior compared to the other, they do have some similar restrictions. For example, they can only be used in adults, and there's a weight limitation based on the size of the device. Usually, patients weighing no more than 300 pounds are able to have this device used. But when we think about what these devices offer physiologically, I think that there's something superior that they can do compared to regular manual compressions. So during the compression, there's a compression over the chest wall that causes ejection of a blood bolus. And then as the chest wall recoils, there's a negative intrathoracic pressure that promotes cardiac filling. That attenuates over time and goes down, because what we'll see is that as the resuscitation progresses, the chest wall compliance goes up, it gets a bit more stiff, it doesn't recoil as much, ribs fracture, and the filling becomes less ideal. The Lucas device helps overcome this by using a suction cup that is applied over the skin of the sternum, and not only does it actively compress the chest wall, but it decompresses it as well by pulling up on the chest wall and promoting filling. I think that this technology represents a significant advance in the field of resuscitation, and although more research might be needed, I think it offers some glimmer of hope and some therapeutic treatment for patients that have a pretty resoundingly bad prognosis. And if we look at the data that's analyzed the outcomes for these patients using mechanical CPR, kind of in the different settings, whether it's in hospital, out of hospital, in the ED, although there's a lot of heterogeneity and different methodologies that were used, overall the results are that it's non-inferior and doesn't show any significant harm or benefit compared to manual compression. So it might be an element of just fine-tuning the use of the device, but I think for patients that have suffered the ultimate complication, going into cardiac arrest, then we have some sort of obligation to provide the best care as possible to them, and using whatever technology we have available to optimize their outcomes.
All right. Any other arguments, David, that you want to make before I pass it over?
I think I'll leave it at that for now.
Okay. Leave room for your rebuttal. So I'm going to hand it over to Melanie. Melanie, you were very excited to play the role of the con person. So have at her.
Yes. Okay. So once again with the glitch, I will use that for dynamics. I think David's probably leaving some eggs in his basket, so I'm just gonna dump my whole basket out and get this all on the table. So the mechanical CPR devices have actually been around for over 30 years, so quite a long time. Surprisingly long, given the fact that so far really there hasn't been any compelling benefits to it, in the sense that at best the evidence shows that it's non-inferior. So David mentioned that it does, you can provide compressions at a certain rate, predetermined, yada yada, which provides a really good monitor display of vitals, better map, probably better end-tidal CO2s, etc. But really, ultimately, good quality CPR, I think, is probably more so measured by the improved survival, and not just improved survival, but improved survival with relatively well-preserved neurological function. And so far, I mean, there have been quite a few studies that have been done, and actually one systematic review and meta-analysis that was done in 2015 by Gates that showed that essentially that it was just non-inferior. So 10,000 patients in this study. They showed no difference in ROS, no difference in survival, and no difference in good neurological outcomes. So by that meaning, you know, they just didn't find that it was superior. So benefits, you know, it looks great. It provides compressions, it probably saves a few people a lot of muscle aches in the morning. But for the patient, ultimately, does it make a difference? Arguably, no, from what I can see. So that's just one side of things. When we look at other things, though, David did mention that early defibrillation was one important part of resuscitation. So going in with that, actually, there was one of the articles or one of the studies that was part of the Gates 2015 meta-analysis was paramedic, also dated 2015. It was a multi-center randomized control trial, 4,470 patients. It was one of the larger studies in this particular meta-analysis. And they compared Lucas to the manual compressions. And what was interesting was that the 30-day survival of patients who had an initially shockable rhythm actually fared much better with manual compressions as compared to mechanical. So manual compressions had 24% survival, whereas mechanical had 18%. Interesting. And also kind of a side note on that, it's a little bit unrelated, but only 60% of the patients in that study who were randomized to be using the Lucas device actually got the device used. So 60% compliance on the use of the mechanical device leads one to wonder if maybe there might be some user-friendly issues, perhaps technological glitches, battery issues. I'm not a huge fan of technology. On a good day, sometimes it's let me down a lot. And when it comes to something literally life and death, I have a hard time letting that go. So going back though to the whole shockable rhythm component, there was a study done in 2006, so a smaller study by Hellstrom, 1,071 patients. It was Canadian and US patients. And this one wasn't actually included in the meta-analysis simply because it was stopped early. Why was it stopped early? Because mechanical compressions were actually shown to show a poorer outcome. But the part that I found really interesting in the study was that the time to shock was actually 2.1 minutes longer in mechanical compressions compared to manual compressions, which when you look at the whole kind of data that was found in the paramedic trial with the 24% manual versus 18 mechanical, there might be a lot more meat to that bone than we're aware. And of course, yeah, that study was stopped prematurely because of poor neurological outcomes in the mechanical group. And they actually had some interesting theories as to why the neurological outcome was poorer in the mechanical compression group. And it leads one to believe that maybe it's because the compressions were too good, and they associated to perhaps there might be some reperfusion injuries. So maybe tired arms are not a bad thing. So that's that. I do have more eggs to bring out, so I'll go ahead and do that. So obviously one of the big things with healthcare in any society, especially in Canada in the middle of a pandemic, is the cost, right? So I believe to drive one of these off the lot is about $15,000 to $20,000. That's a lot of money for one unit. So with your whopping $20,000, you simply get to carry the case out and bring it to wherever it's going to be. So you get one unit allocated to whoever, I guess, has the more pull in the department or in the healthcare, who knows. So to supply any substantial amount of these to make any substantial difference and change procedures would be a huge expense. And this is just to get the product. We still need to have maintenance. Batteries presumably need to be changed and maintained. I know that some parts of it are actually disposable, the suction cup things. I presume a medical grade suction cup must be a fairly expensive thing. I've never bought a medical grade suction cup, but Alan, perhaps you could shed some light on how expensive a suction cup is. I'm going to go ahead and say maybe about $250. Yeah? Okay, cool. Good guess.
Let me Google that right now for you, Melanie.
Thank you.
It's
That
just
would be
lots.
great. That would be great. So let's just assume that, aside from the suction cup, the batteries, there are some more expenses, because of course they're going to be. But I think the big expense would not just be the equipment and the maintenance of the equipment, but rather the training that you have to provide everybody who's going to be using the device in order to be able to use it safely, right? So some of the studies that were done actually used sort of like a pit crew type analysis. They had these people using these devices trained like pit crews, running crazy with it, that they were almost on autopilot. Well, that takes a lot of simulation. And simulation means money, right? So you've got to pay wages to the trainers, the trainees. You also need to have appropriate mannequins to be able to do that on. And I'm going to state the obvious that in North America, perhaps the standard mannequin might not be more representative of the North American population who's going to have any cardiac problems and require mechanical compressions. So in order to really adequately train on this device, you want to be able to train not just on a perfect BMI of 25 mannequin. You need to have a good variety of them, and more authentic and lifelike, the better, right? So that would be very difficult. And an area as well, like in most places in New Brunswick and some of the more rural parts of the country, we just don't have the volume. So you'd have to have constant simulations all the time to be able to maintain those skills. And then on the argument of maintaining skills, I mean, while you're focusing really hard on this, what happens with skill atrophy for just the straight up manual CPR? If you don't use it, you lose it. I mean, I tried to ride a bike not too long ago. Dude, it did not go well. And I mean, it had only been a few years, right? So I don't want a rookie compressing my chest, because it's not going to end well. So that's the second argument is the cost. And the third argument is actually the potential for injury. Now, this one was rather frightening to me. And I watched a video of this device, and I feel like it maybe filtered out a lot of the scary noises to kind of make it more appealing, with the nice fancy music of, look at this wonderful device, to hide and cover up the sound of the breaking and shattering bones. So the Gaze 2015 meta-analysis didn't show any significant harm. I do wonder, I didn't read much detail into how they trained the people, who was excluded and excluded and all of that. But what I did find was a fair number, actually, of studies that had found that there was some harm associated with this. So just a reminder for everybody, so far there have been, at best, mechanical CPR has been found to be non-inferior. So using some common sense here, if we have something that's non-inferior, that to me means as good as, right? So in this case, we need to be really cautious about what kind of harm could be brought on by something that's non-inferior. So there are a lot of post-mortem studies that did reveal that there was specific patterns of injury associated with these devices. Koja and Associates 2015, for example, found that there was an odds ratio of 30-1 for posterior rib fractures with the use of mechanical CPR devices. Rib fracture is kind of a big deal when you got someone who's already in a precarious situation, right? And where you have one fracture, you probably have more than one. So this was a study, it was fairly small, about 323 patients, but there were quite a few other studies about the same size that has similar findings. Not to mention there are a lot of case reports that have been published showing a really lovely selection of menu of injuries. Just to wet the palate a little bit, we've got some substernal hematomas. We have thoracic and abdominal aorta rupture. It probably has poor outcome. A pericardial bleeding, liver parenchymal injuries, vertebral body fractures, and my favorite was the exploding pancreas. That didn't end well. That the patient passed of the exploding pancreas. Other organs have exploded as well, the spleen, the liver, but the pancreas is pretty far back there, I thought. So
did
that's
it actually
that.
Did it actually go boom?
They did a postmortem CT, which showed that it had at one point boomed. I don't know. It wasn't live imaging, but it would be a really interesting study, actually, if you could do some kind of dynamic imaging while you're compressing. Perfect resident project. I'm sad I've done mine, because that could be interesting. Perhaps a partnership with DI could be in order for this. So anyways, all that to say, these are not benign devices, right? So especially when you're dealing with patients who are not a standard size, standard shape, these are put in a hurry, maybe by people who haven't put many on before, or, they're newbies, and fair enough, everybody's got to start, but with manual compressions, you can adjust your compressions. If you feel, the crack, you might, just adjust accordingly, right? So those are my eggs. That's my basket. So I'll leave it to that.
Wow. All right, Melanie. David, any rebuttals?
Yeah.
I know we had a chat this morning. I know you've got rebuttals.
There's some good points raised, but I think there's some arguments against them. And although some of the studies have shown non-inferiority or some competition between whether manual or mechanical CPR is better, I think we have to keep in mind the risk of bias in some of these studies, especially when different resuscitation staff and operators are under observation. There might be some element of the Hawthorne effect, where just the fact that these staff are being observed, being trained probably before engaging in the study, whether it's with the mechanical CPR or manually, they probably have a acutely higher awareness for what high quality CPR is, and they're probably attaining better chest compressions than people would in real life with outside of the study setting. And if and although some of those individual RCTs do show that there's disparate outcomes showing improvement with mechanical versus manual or no benefit, the studies that I'd like to point out are RCTs from in-hospital cardiac arrests that looked at in-hospital use of mechanical CPR in albeit smaller groups of patients over the years from the 70s up until now. But those studies have shown significant improvement with mechanical CPR, and I think it was a 2014 systematic review and meta-analysis that compiled these studies and 3 others that looked at in-hospital arrest found that there was a statistically significant improvement in 30-day survival with mechanical CPR with an odds ratio of 2.3, and that a 95% confidence interval did not include 1. It was 1.42 to 3.85. So I think there's significant support there to at least consider it in the in-hospital setting. Now, the question though also about the other the studies that show no benefit or marginal benefit, I think in those we have to keep in mind the population that we're dealing with. Cardiac arrest patients are a really heterogeneous group that come from a variety of ages and a lot of different pathologies. So I think that's going to really spread out the spectrum of results that we'll see. And also it's going to really affect just how, what kind of results we end up seeing. And I think Melanie also brought up the issue of the cost. So although the cost here of the device can be impressive, $15,000 a unit with the ongoing maintenance costs.
20.
Yeah. So it will, in the long run, potentially pay for itself. I think the benefit of having a device like this is in the cognitive offloading that it does for whoever's leading the resuscitation. They're not going to have to worry about observing the chest compressions are the appropriate rate, depth, keeping in mind that the different operators are changing, switching off every 2 minutes or so. And I think that's going to streamline the resuscitation and also decrease the chaos. Anyone that's been in a resuscitation will see that there's a lot of staff there. There's a lot of clutter around the bed, around the patient. And sometimes it's hard to even enter the room just because there's so many people and there's a line of people waiting for their 2 minutes to do chest compressions. So having a device like this is going to open up space so that the whoever's managing the airway can get to the head of the bed. Whoever's getting IV access can get to the sides, and it's also going to streamline communication and really promote closed loop communication. With training for this, I think that although we haven't seen it make its way yet into societal guidelines, they have started to mention it in terms of specific patient populations that should be used for. But I think although ongoing simulation will be required, we're already doing simulation and recertification for ACLS. And I think one day this may make its way into that program and we'll already be exposed to that training, and it'll recur on an ongoing basis, even outside of seeing it in the clinical setting. The other study, or the other argument that I'd like to bring up here in terms of the benefit that can happen, and I think this is more of a topical argument given the times that we're in, given that over the last few months we've probably been all more acutely aware of patients that are coming into our hospitals and into the department, especially if they're undifferentiated and we don't know what illness they're coming in with. And if they've arrested, not knowing the cause of the illness, we're considering whether they might be COVID-19 positive. And we're more aware of wearing personal protective equipment, who is being exposed to different patients. And if we can somehow reduce the staffing that are required in these resuscitations, it's going to, I think, be a benefit in public health emergencies like this, where there's going to be fewer people ultimately exposed to potentially infectious patients, especially during aerosol generating procedures, which would inevitably be occurring during CPR potentially. And then lastly, in regard to the point about harm that these devices can be causing, although it's noted that there have been some reports of significant injuries, some of that is observational and anecdotal. And the studies that I'd like to point to are our systematic review or rather RCT by Smeckel from 2014. It was a Swedish study and it looked at 222 participants, 83 of which had manual CPR and 139 had mechanical CPR. And this study was undertaken because there was data from two earlier studies that revealed no difference in incidence of injuries and between the methods of chest compression. And this study found the same, that there was no significant difference in the harm. And a Cochrane review from 2018 that primarily looked at RCTs and some observational studies, which found no significant difference in benefit, found the same, that although there might be some differences in the distribution of injuries and the number of rib fractures, for example, which are inevitably going to happen whether it's manual or mechanical CPR, the actual effect that has on resuscitation outcome, as determined by forensic pathologist consensus, was that these don't seem to have an impact on the outcome of the patient's resuscitation.
Presumably, yes. Presumably, they were not successfully resuscitated if it was the forensic pathologist. I'm sorry. Okay. All right. So I'll rebut on a few of these. So starting, I guess, with the original argument. So the in-hospital cardiac arrest. Yes, there have been actually 3 randomized controlled trials that I'm aware of. One in '93, one in '78, one in 2010, and yes, that's 1978. And the total of patients in these trials was actually 235 patients, combining all three. And out of these three trials, none of them actually looked at the outcome of neurological function. So we know these patients were alive in that they were breathing and presumably had a pulse 30 days after the arrest and the resuscitation, but we don't know anything about the quality of life. They didn't look at that. They didn't look at the outcome. So again, just given the fact that the stuff that I quoted earlier on about potential maybe reperfusion injuries and poor neurological outcomes in a much larger trial, I think that calling that a win is maybe not appropriate. So 235 patients. There are a lot more resources in hospital to do manual compressions, right? So one of the arguments that I can get behind with mechanical CPR is that perhaps it can be used when manual compression simply cannot be used in transport pre-hospital. Yes, but in hospital, there's always somebody hiding in some deep dark corner. And before I was even in medicine, as a staff in the hospital, I was required to certify for CPR every year. So the housekeepers are probably CPR certified. So I mean, you've got the resources that can help you out. So I don't know that in hospital cardiac arrest would really benefit from these devices, especially not on the really scarce studies that we have available at this point in time. Again, dating 1978. There's actually the 1978 study was 50 of those patients. Yeah, okay, we'll leave it at that. So moving on to the next argument, David mentioned that the patients receiving cardiac or resuscitation were a heterogeneous group. Exactly, very heterogeneous in size, and that's going to be an issue. You can easily adjust where you're doing compressions with manual CPR. You know, if you're not getting appropriate compressions, you move up a little bit, you move down a little bit, you move over a little bit. But every time you have to move these mechanical CPR devices, you got to stop, you got to shimmy up, you need people to lift and tug and pull. It's just simply not easy. And it takes people to do that. So you're going to have, instead of having a lineup of people waiting respectfully and quietly to take their turn in compressions, you're going to have this hubbub of people trying to set this mechanical device in an appropriate position. So I'm not sure that it would really be that big of a cognitive offload for whoever is trying to run this code. I think maybe, you know, if it is such a cognitive issue for the leader of the trauma to have to monitor appropriate compressions, perhaps we can just have, you know, a CPR person who just looks at the CPR compressions. They can be wherever on a walkie-talkie, like, hey, go a little faster, go a little harder. You know, it doesn't, you can still cognitively offload without actually having a machine doing the work for you.
Like a CPR coach.
Right.
Yeah.
Yeah, exactly.
So Melanie, I'm going to just stop you there for a sec in the interest of time. I've got this scored very, very closely, although I've actually scored it a tie until the pathology rebuttal came out. That was a pretty good one. But I want to hand it over to Alan for a sec, just to speak on experience with these devices and what does he think about mechanical CPR in general.
Thanks a lot, Angus. First and foremost, mad props to Melanie and David here for such a fun and informing debate. Learned a lot, learned a ton. It was fantastic. I think briefly, my thoughts have all been covered in this wonderful debate. For example, I think it does, the mechanical CPR does have an excellent benefit for human factors. So it does chill the room out. It's fantastic for transfers. So I would argue that it would be excellent for those sites that don't have PCI. It's also wonderful if you need to transfer or you are an ECMO capable facility to have Lucas to free your manpower up to be able to access the groin for a crash VA, for example. Now, perhaps British Columbia is a little warmer than Atlantic Canada, but the mechanical CPR is phenomenal for those hypothermic arrests too, when you know it's going to take a while to keep them warm. I do echo Melanie and David's comments that that mechanical CPR is bad for a shockable rhythm. So though it should not take away from good quality immediate resuscitative care, which is early defib. And I think that the Nalenzuela, I hopefully I'm pronouncing that last name right, the Nalenzuela paper in NEJM found that it was like a number needed to treat of like 2.5 for a shock for VF. So I don't want the mechanical CPR to take away from that good quality things. Now, there's something that I do want to highlight that often doesn't get mentioned about mechanical CPR. So bear with me. I'm going to share my screen. Oh, Angus, can you give me permission to share my screen? I promise it's nothing naughty. Now, this is the stuff.
I don't know. I don't trust you, Alan, right now.
You see, this is the stuff that that the manufacturer doesn't talk about, nor does the literature talk about. So this is specific to Lucas, which is which is the device that we use at my shop. And
how do I let you share your screen?
So you just go to the participants window there, and you hover over my name, you click more, and you should be able to be like make something.
Host.
Make host. Perfect. Excellent. So this is something that they don't advertise. So I'm the host now.
There you go.
Oh no, this is trouble.
It kind of feels like I'm like that character from that Tom Hanks movie. But I just want to show you this here. No one talks about this. And when we talk about costs, this thing here always breaks. That's where the plug-in is used to charge.
That's the battery, isn't it?
That's the AC adapter that charges the damn thing. And but if you're going to reach for a mechanical CPR, specifically Lucas, chances are you're going to be grabbing it off the wall because it's always on a wall. And this thing always breaks. And that thing costs like $500. So anyway, just food for thought, something that I learned because I broke it last year. Now I got to give you a fun case to put this Lucas into perspective here. I live in Vancouver, and we have an international airport out here. And there was a man that flew home from Thailand. He had some unilateral calf swelling, and then he developed shortness of breath on the flight. Classic PE story, right? He gets himself in a cab at YVR and gets himself to Vancouver General. Shows up at the door, and he's like, yeah, I don't know. I'm a little short of breath. I don't know, a little bit of pleuritic chest pain, etc., etc. Take one look at him, and you'd be like, that's not supposed to be your color. You're not supposed to be that color. That's incompatible with life. We bring him into a normal room, and right in front of us goes into a PEA arrest. Classic PE, right? So early CPR, it was a non-shockable rhythm, and this was a perfect case because we slipped him on the Lucas, and we were able to cannulate him for VA ECMO. So long story short, he had a 48-hour stay in intensive care on VA ECMO, neurologically intact, vasopressors, inotropes, etc., all weaned, ECMO weaned after 72 hours. At 96 hours, he was doing Sudoku with his nasal prongs. Pretty amazing stuff. And the Lucas helped buy that time for the team to be able to cannulate, activate, etc. So that was a huge benefit. Now, I'm not biased because there was a downside. The reason why it took him 96 hours to get out of ICU for a PE that was treated was the Lucas was originally put too low. Now, there was a paper there was a Coster paper back in 2015 that looked at safety devices for a Lucas compared to manual CPR, and they looked at serious injuries. They basically said that the Lucas is safe, and then for the Autopulse, it was inconclusive. Taking this for what it's worth, this is simply just a story. The Lucas device was too low on his sternum. It was over the xiphoid process for the first 10 minutes of CPR. His end tidal was okay, so he was perfusing with the CPR, with the compressions. But he ended up hypovolemic when he got to critical care because he had a liver lac from a fractured xiphoid.
How was his pancreas?
His pancreas did not blow up, although his lipase was unhappy with us. So he ended up getting mass transfused in the ICU for a liver lac and ended up going to the OR, not for his PE, not for TPA for the PE, but because he had abdominal compartment syndrome, and that delayed his discharge from ICU. He ended up perfectly fine. But anyway, it's just food for thought. That was just one story that sticks with me.
He did not need the forensic pathologist then?
No, no, I don't think anyone would approve that one.
Okay.
There was no COVID yet, so no one approved it.
So,
yes,
yeah, go ahead, Alan. Go ahead.
So, in summary, I think that in my practice and experience with it, I think it's a phenomenal device. And like any other piece of technology, I think it comes with a point of care assessment. I think that we need to look at the big picture, look at the forest and not the trees, and see if this device that we have is useful in our care for the patient. And I would say that if you don't have a PCI, one would be a PCI lab at your facility. It's excellent to have there because it's wonderful to have in the back of that truck.
Yeah, absolutely. So I think I'm gonna score that debate pretty even because that was really impressive. The two of you did a hell of a job. So huge
Very much
props
so.
to both of you. I would kind of agree with Alan on everything here, and what I've heard from both Melanie and David. I would summarize it myself as focus on high quality CPR and don't lose sight of the bigger picture, and not focus too hard on a brand new shiny device, and that it might not actually be for every single patient. So understand who you want to put that on. I see it as it's a bridge to somewhere, not a bridge to nowhere. So I see it as a bridge in the back of a truck to get to a hospital. I think it's very useful there. I could see it locally in our advanced care paramedic trucks, so you're not costing out every single truck, but maybe 2 or 3 in the city would be a good idea. In a huge refractory VF or VT case that you're trying to get to a cath lab. We talked about ECMO, so a bridge to ECMO, and those hypothermia patients that take a long time to rewarm, you're going to fatigue. So I think those are certainly the big things, and maybe COVID. David hit on that. So limiting personnel in the room is always a good idea. I know Jacqueline and I came across a paper about what was it, the N95 masks that kept coming undone with people giving lots of manual
Have
CPR.
you ever done CPR with an N95 mask on? I'll tell you right now from personal experience, it does not appropriately.
No, I bet. I haven't done it, but no, I believe you. And then my last plug would be there could be harm in these devices, so we have to be careful. And so training is a must. So I'll put my plug in for, simulate over and over again. And there's been a randomized control trial just back in 2019 that showed, less error and less downtime to apparatus application with regular simulation. Alan, do you simulate this out in BC?
Yes.
With the Lucas, with the Lucas device itself, eh?
Yes,
okay.
Because despite how fancy and shiny the device is, there does require some fine motor movement, which is difficult when your adrenaline exceeds that of the total amount of milligrams of epi on a crash card. For example, speak specifically to the Lucas, you need to get the suction down, and that's off. It's just the one small thing that can really hiccup something and delay compressions. So definitely need good simulation.
One extra indication that I would add to that list that you mentioned, besides the ECMO, is one that that isn't talked about too much, but has been recently researched, and that's heads-up CPR, where the head is elevated to decrease ICP, improve cerebral perfusion pressure. And it's not part of any really recommendations or guidelines, but that's a position that'd be really hard to do manually. And mechanical CPR, if positioned appropriately, can help optimize compressions in that case.
So David, you just tied Melanie for the pathology comment with the heads up CPR. So it's definitely a tie now. I was feeling a little guilty there. I was like, oh, that was a really good one. Boom. I scored 8 for and 8 against. So I think we're a dead tie. Any other comments from any of the panelists? Or Jack,
so
is there
there's no questions so far, but one of our wonderful paramedics actually brought up the point of having staff in the hospital, of actually having the Lucas device decreases staff requirements, allowing for patients to get better care and proper care. This paramedic was mentioning, Chris, I'm just going to call you out. He had messaged me and said, it actually helps eliminate fatigue, compressor fatigue, with it in transport in the truck, especially in rural New Brunswick.
Absolutely.
So he was mentioning that, and he just personally messaged me, "You're welcome, Chris. You're welcome." So yes, rescue or fatigue injury is another thing that he would mention. That with the muscle fatigue of doing CPR in the back of an ambulance for 20 plus minutes here in New Brunswick, there is greater risk for injury, and you're moving and going. So with the Lucas device, it actually can help with that. So.
Oh yes, the transport times in rural New Brunswick to a tertiary center are quite long, isn't it? Aren't they?
Well, even in our city, Alan, there's protocols in place that they have to do 20 minutes of on-scene CPR before transport, regardless. So 20 minutes minimum.
I didn't consider the local environment.
Protocols.
That's an excellent comment by Chris. Yeah, that's great.
Yeah.
Anything else, Jack, at all?
Not really. No. If there's anybody who wants to put anything out there.
I would like to.
Oh, no, not you, Alan.
The Zoll styled mechanical CPR I find to be quite useful because it's the one that straps over your chest. It's like a backpack over your chest, and depending on how your environment is laid out, that actually helps with your logistics, because it's smaller and there's less space. I'm talking with my hands here. Less space above you that's required. Whereas the Lucas is this huge device that takes up a lot of space, like superior to the patient, and that sometimes can be a barrier. So just things to consider.
I wondered that, because I wondered if that would be a little bit of a barrier.
Yep. And one little thing that we did that at Vancouver General, when we first got the Lucas, what we didn't think about was we assumed the battery would be good. We assumed the battery would be equivalent of that of your old BlackBerry phone that you used to use in the early 2000s. Those BlackBerries never died, right? Well, these Lucas devices, because as soon as it goes on, people are then going to get more comfortable with it because your end title's good and your codes go just a little bit longer until the battery runs out. So you need to get an extra battery. And let me tell you that ain't cheap.
How long does the battery... Yeah, that's right. How long does the battery usually last, Alan? Roughly, do you know?
I don't know off the top of my head. I really don't. There's options where you can do the 30-2 ratio, or you can do continuous. I would reckon that it would. I reckon that it would die if you keep it continuous, more so than the 2-1. And Chris has the question: is can you run it while plugged in? I never tried that.
I feel like that'd be a safety hazard for us as staff.
Yeah, and one extra wire for the poor the poor med student to trip over because they're next in line for something, right? So,
Yeah, and you know what? It's actually a good point for Chris. For Chris the paramedic, not Chris the RN. They can't plug it in the truck. He's just saying, but in the truck maybe it would, but yeah, can't do it on the actual on the scene. But maybe in our trauma room we could. But
this has been a lot of fun and very informative.
One other question, or
yes.
one other statement. I did Google how much a suction cup was, and according to some random Google search or whatever, for a price of 3, where did it go? Shoot, I'm sorry.
You're not looking at the Kirkland brand suction cup, right? Because someone's dead here, so they should probably get at least
Costco's high quality, okay?
Oh,
Costco's high quality.
I got Kirkland sheets. They're great. They're very soft. Okay, they keep me nice and cool at night.
It runs between about $200 to $600, give or
For a
take.
suction cup.
For the suction cup, a pack of 3. A pack of 3.
For a pack of 3, okay. So
a pack of 3
for a suction cup.
Yeah, I'm
not
sure.
Not reusable.
Right, and of course, it's probably going to depend on whether it's the Lucas 2 and 3. It's probably the same little puck, but I'm sure they have little deals with Stryker that they could. Yeah.
Okay.
Anyways, last comment. That was it.
Super great points. Melanie, thank you very much for your hard work. Thank you very much, David, for your hard work. Alan, thank you so much for joining. It's actually been super fun to have you. I never know where it's going to go, and I'm always concerned it's going to go sideways. But
here's one question.
Going inappropriate, okay? You can always go inappropriate. That's all you know with me.
This is maybe another topic that we could maybe do another panelist discussion or whatever. Brought up the point of never using this in a pre-hospital traumatic arrest. And Alan would be lovely to talk on that.
Well, Alan and Rob delivered a hell of a talk in December for our half day in the recess day on traumatic arrest and compare and contrast. That would be a good one to do again. That went over very well.
Yeah. Anyways, so
good point.
All right, now I'm done.
You're done. Thanks so much, Jack, and thanks to everybody. Hope
Great.
to do it again. And again, Melanie and David, well done.
Yep.
Amazing.
Mad props to you. Good job.
Yep.
Thanks for the opportunity.
It was a good time.
All right. Have a good night, everyone.
Bye. Thanks, everyone.
Take care.